Hello, my name is Anthony Wilkinson. I am focusing my epidemiological project on measles, which I feel is becoming a very notable topic in today's media. So, what is measles and how does it present? Measles is an infectious disease caused by a virus. It spreads easily from person to person. It causes a blotchy red rash. The rash often starts on the head and moves down the body. Some other notable symptoms are fever, typically greater than 102.2, a cough, runny nose, conjunctivitis, have generalized feelings of aches that run throughout the body. You have tiny white spots inside the mouth. Currently, today, we don't have a treatment for measles. The focus surrounds symptom management. So, to get a generalized understanding of measles, we want to look at the pre-vaccination era. In the 19th century, a Persian doctor published one of the first written accounts of the measles disease. His accurate description of measles was recognized by the World Health Organization in 1970 and recognized as the first written account of the condition. In 1757, a Scottish physician determined that measles was an infection of the respiratory tract and could be found in the blood of infected individuals. This physician was Francis Holm. He attempted to develop a measles vaccine, however, his vaccine experiments were not successful as the measles virus had not yet been isolated. It wasn't until 1912 that measles became a nationally notifiable disease in the United States, requiring healthcare providers and laboratories to report all diagnosed cases. During the 1920s, the United States had nearly 400,000 recorded cases of measles and 7,000 deaths associated with measles. From the years 1958 to 1962, the U.S. averaged nearly 500,000 cases and 6,000 deaths associated with measles per year. Here, we are going to look at the infectivity of the virus. Infectivity relates to the ability of a pathogen to establish an infection. More specifically, infectivity is a pathogen's capacity for horizontal transmission, that is, how frequently it spreads among hosts. Infectivity is close to 100% in susceptible individuals, and in the pre-vaccine era, measles would affect nearly every individual during childhood. What is very concerning about this disease is that it is a disease of humans. Humans are the only natural host for sustaining measles virus, which makes the global eradication of measles quite feasible. The virus is typically spread through coughing and sneezing. It is highly contagious and lives in the nose and throat mucus of an infected individual. The virus can actually live up to 2 hours in an airspace where the infected person has coughed or sneezed. Infected people can spread the virus to others from 4 days before to 4 days after the rash appears. Here we have the pathogenesis of measles. Pathogenicity is defined as the absolute ability of an infectious agent to cause disease or damage in a host. An infectious agent is either pathogenic or not. Measles is a systemic infection. The primary site of infection is the respiratory epithelium of the nasopharynx and regional lymph nodes. 2 to 3 days after invasion and replication in the respiratory epithelium and regional lymph nodes, a primary viremia occurs with subsequent infection of the phagocytic cells within the reticular connective tissue. Following further viral replication in regional and distal reticular sites, a secondary viremia occurs 5 to 7 days after initial infection. During this viremia, there may be infection of the respiratory tract and other organs. The measles virus is shed from the nasopharynx, beginning with the prodromal stage, as mentioned earlier, that begins around 3 to 4 days after rash onset. When looking at virulence factors, we focus on a pathogen or microbe's ability to infect or damage a host. As previously mentioned, the portal of entry for the virus is respiratory mucous membranes. Once the virus has penetrated the mucous membranes, it can then spread through the lymphatics and bloodstream. This can cause a systemic effect that allows the virus to affect multiple organs within the body. When looking at attachment to the host, we look at hemagglutinin, which is an internal membrane protein found on the surface of the measles virus. Hemagglutinin then binds to CD46, which is a glycoprotein found on the surface of most cells. These cells protect the host cells from autoimmune destruction by binding to C3b and C4b and cleaving them. Basically means to replicate the body's immune system cells. By doing this, the virus can evoke immunosuppression. The measles virus blocks T4 proliferation response to interleukin 2. Basically, the virus inhibits the body from producing the natural immune response needed to fight off the antigen which is attacking the body. We begin to see the maculopapular rash when we start to have destruction of the tissue. So this is the rash that starts at the hairline and spreads over the whole body. It is caused by the immune T cells targeting the infected endothelial cells of the small blood vessels. And interestingly, T cell deficient individuals do not have the rash, but still have the uncontrolled disease, which usually will result in death where it goes unrecognizable. So here we can see that the virus causes immunosuppression, while in return, the cells that we still have that are trying to fight off the infection are in fact attacking itself. The body basically turns on itself and causes its own destruction through this process. The damage, as well as the control of the disease, is most directly caused by the immune system itself. It wasn't until an outbreak occurred among Boston, Massachusetts students in 1954 that researchers Dr. Thomas and Dr. John were successful in isolating the virus. The measles vaccine development began soon after this discovery. This process was achieved by collecting blood samples from several ill students during a measles outbreak in Boston. They wanted to isolate the measles virus in the students' blood and create a measles vaccine. The vaccine worked by triggering the immune system to produce antibodies against measles. If an individual then comes into contact with one of the diseases, such as the measles, mumps, and rubella, which is how the vaccine is currently supplied today, the immune system will recognize it and immediately produce the antibodies needed to fight it. The measles vaccine produces an apparent or mild non-communicable infection. It contains weakened versions of live measles, mumps, and rubella viruses. Research has shown that measles antibodies develop in approximately 95% of children vaccinated at 12 months of age and 98% of children vaccinated at 15 months of age. It was also found that approximately 2 to 5% of children who receive only one dose of the MMR vaccine failed to respond to it. It also showed that the majority of people who fail to respond to the first dose will respond to the second dose. Today, a single antigen measles vaccine is not available in the United States. It is due to the concern that if separated, individuals may miss follow-up appointments and not receive the extra doses, or that the community would not be appropriately vaccinated. And although vaccination is considered the front line of defense for measles, it is important for healthcare officials to understand when it is not advisable to get vaccinated. According to the CDC, some main focuses are um, life-threatening allergic reactions, pregnant women, immunocompromised individuals, those who have HIV, if you have active tuberculosis, if you have received any other vaccination within the past 4 weeks, or if you're moderately to severely ill. It is not advised to get the vaccination. Some interventions for the family nurse practitioner to consider involve preventing, identifying, and managing outbreaks, educating the population that we serve in our community, identifying high-risk populations, those who are partially vaccinated or not vaccinated at all. We have pregnant women. The consequence of a measles infection for pregnant women they can experience miscarriages, stillbirths, or preterm delivery. Babies that are less than a year old are highly at risk. Individuals who are severely immunocompromised, again, such as HIV patients. Individuals who have recently traveled to an endemic area or one with an ongoing outbreak, or if they've had any close contact with an infected individual. The nurse practitioner should also be aware of detecting signs and symptoms. Being able to identify symptoms early can lead to properly being treated and decreasing and improving our mortality rates. It is also very, very important to understand the process of notification to surveillancing bodies, such as the local health department. Some interventions we can look at for infection prevention and control. First and foremost is that measles is preventable by the vaccination. It is vital for the family nurse practitioner to educate and inform community members of the importance of routine vaccination programs. High uptake is vital in the control of measles and for the prevention of an outbreak. We like to see herd immunity, and the WHO recommends 95% of eligible population be vaccinated to achieve this herd immunity. 2 doses of the vaccine are required to achieve immunity. The first is usually offered at the age of 12 to 15 months, and the second dose is normally around 4 to 6 years of age, although missed doses can be offered at any age, including adulthood. As the disease is highly contagious and transmitted through coughing, sneezing, direct face-to-face contact, suspected cases should be isolated. This is why it's very important for the healthcare provider to identify these symptoms and this issue early on, which will also in turn help infection prevention and control the disorder itself. By placing suspected cases into isolation, healthcare providers can decrease the transmission to other unvaccinated, immunocompromised, and even pregnant individuals. So when looking at the notification process, under the Health Protection Regulations Act of 2010, registered medical practitioners are legally required to notify suspected measles cases to the local health regulatory agencies. Once a notification form has been received, health protection teams will undertake a risk assessment of the patient. The risk assessment includes the need to provide public health action for any vulnerable contacts. The risk assessment includes discussing clinical presentation, whether they have been in contact with any active cases of measles, and any recent travel and information about their close contact. When we look at the susceptibility of those workers who are exposed to the potential measles diagnosis, it is determined by assessment of the worker's vaccination history or evidence of serological immunity. In conclusion, measles is a highly contagious disease which can have very serious consequences. It is a 100% preventable disease, meaning there is a potential for complete eradication from our society. The only way this can be obtained is through public awareness and community education. As healthcare providers, it is essential that the vaccine uptake is encouraged at every available opportunity with interaction with our family members, our loved ones, and our patients.